Okay, let's get started. Today we have a very special guest, Dr. Fong, and he is in Indianapolis, and he is a addiction medicine expert. And we are actually re-recording this episode. So we already met a couple of weeks ago, did this, had technical difficulties. Just so you guys know, if there's any nuances in our conversations, which I'm really repeating, but we have Dr. Fong here. I feel very privileged, and it's interesting how I met him, or we came to know each other. Nicole, who, as many of you know, online, sent me a text with some of his TikTok stuff, and he's like, "Hey, Dr. B, look, here's you on the East Coast," and I looked at this stuff, and I was like, "Wow, he's amazing." So we got together, we talked, we shot this video about a week ago, and it went technically south. We're going to do it again. The topic today is going to be how to get off Suboxone. You're going to find this stuff really, really interesting, useful, and hopefully enjoyable. But I think you're going to get a whole new understanding. It's stuff I've talked about in the years past. But first, let's get to know Dr. Fong a little bit. He's an addiction medicine expert. He has a new book coming out. Actually, his book is also now out now. Abstinence Kills. Dr. Fang, welcome back. I'm sorry about the technical difficulties we had, and I'm really happy you're here with us today so we can do this again. Hopefully it'll be
I'm
better
delighted
than
to
last
be
time.
here. Thank you for inviting me. And we do live in this world where we're always held hostage by technical issues. Yeah,
We sure are, right? It's funny. It's supposed to make our lives easier. Why don't we start again where you tell us a little bit about yourself, what you do, and I do want to know about your book, and we're going to have the links that give the viewers access to you below, including your book. Why don't you tell us, take 5 minutes, tell us a little bit about yourself, and then we'll dive deep into how to get off
sure. Thank you for
Suboxone,
the
if you will.
opportunity. Well, I started off as a family doctor, and I've been a physician now for 40 years. And I fell into addiction medicine by accident. And I was around when the whole opioid epidemic erupted with Purdue Pharma and things like that. And I was at ground zero, and I saw a lot of my patients who fell victim to addiction. And as a family doctor, I was privileged to get a side that a lot of people don't see. I saw patients that were um, good, hardworking people who loved the family, who got hurt in the job or something and got put on high dose opioids, and then lost their prescriptions because of various reasons, and then ended up resorting to getting medications off their friends and family, and before they knew it, they lost control and became addicted. I then had to learn how to uh, treat addiction, and I started writing buprenorphine, and I was amazed at how well these people responded. And within a short period of time, they were back to being functioning people, being the same good, hardworking family people that I had known them to be. And that was, for me, proof positive that addiction is a disease, because I saw somebody that was, that I knew to be healthy, and then they came down with an affliction. We gave them medication, and they returned to the state of health. If that's not a disease, I don't know what is. I don't know what it could be.
Let me let me ask you a
Mhm.
question which I'm curious about. At the time, you were still practicing family practice. You started doing this. How many years
This
ago
was,
was this
the yeah,
when you first
this would
started?
be in the early 2000s. Okay.
Okay. My question to you is this. When you started writing for buprenorphine products, Suboxone, whatever, did you approach that at that time, or were you aware of the stigma and biases towards this medication? Because I know a lot of people that won't even go near it and they don't even understand addiction. But it seems like you very wholeheartedly approach this without any biases or judgment. What was going on in your mind at that time when you started this
Yeah.
whole gig?
The when I started doing this, the opioid epidemic had not even been formally declared because, as you may remember, the CDC declared the opioid epidemic in November of 2011. And by that time, most of us on the field were really aware that there were issues going on. And so the issue of buprenorphine was not so, there was very little stigma around it, excuse me, at the time because very few people used it. Very few people knew how to write it. And so there wasn't that kind of a stigma. Though I have to say that, you know, at that time, I was probably guilty of a lot of the prejudices and stigma that I fight every day now. Okay. I tell people I did not go to medical school thinking when I grow up, I want to be treating heroin addicts. That's just not what people we think. Okay. But once I started treating addiction, I realized that this is the most rewarding thing I've ever done in medicine because I get to see young people and we put their lives back together and we make such a big difference, not just for the patient, but for the patient's family, the children, the next generation, generations yet unborn. We help their families. A lot of times they're already now living with grandma because their parents can't handle them anymore. And we have a multi-generational thing. And also we get to see the fruits of our labor, that how well they come along. So that's kind of how I ended up falling into addiction medicine. I tell people that I loved being a family doctor. I really liked it. It was very gratifying. It's one of the few areas of medicine where we see the full spectrum of humanity, and we treat them longitudinally over time. It's not like just seeing them when they're sick. We see them when they're sick, when they're healthy. We see them when they're young, when they're old. I saw the full spectrum of humanity, the good, bad, and sometimes the very ugly. We saw people from what we call womb to tomb. I was doing prenatal care all the way to, end of life care. And I loved it. But then I said, wow, addiction medicine, it's really worthwhile doing because we make such a big difference in the people's lives. And like I said, when you come across it from it that way, it becomes crystal clear that this is clearly a disease because medications can help. Having said that, there's just like any other disease in medicine, nothing responds 100% to the same medication. It doesn't matter if it's a heart problem or you've got pneumonia. Sometimes this antibiotic doesn't work. We got to switch to that one. Sometimes this doesn't work. That doesn't work. And, I became an addiction doctor because I wanted to get better at handling the harder cases because I knew that these people also needed help. So that's kind of the brief introduction is how I
Sure.
got into addiction medicine.
And here we are years later. Your book just, I think, got published. Tell us
Sure.
about that
Um,
book.
what I realized was that I found that a lot of patients who were dying of drug overdoses had actually stopped using drugs at the time that they overdosed and died. Okay? This to me was such a big tragedy because they had come along such a long way. And sometimes I call it snatching defeat from the jaws of victory, rather than the other way around. Because there are people who've done well, they've managed to stop drug use, and then they relapse and they die. And I began to realize that people were dying from a state of abstinence when they're not using any drugs. And people normally say, how could abstinence kill you? Abstinence is not using drugs. Why we're not using drugs? How could that be fatal? The reason is because when people get off drugs for any reason, they lose the tolerance. And nowadays, in today's day and age, when the opioids out there are so potent that a single fake pill can kill you, there's no room for error. And now, if you relapse, if you lose tolerance, it's very easy to die. And I know that a lot of books on addiction have been written trying to get people to teach people how to heal from their addiction. And some people say, well, it's a disease. It's not a disease. It's a developmental problem. This, that, the other thing. All fine and good, you know. But as far as healing from addiction, as I tell people, if you stop using drugs today, your problems are not over because you remain at high risk of relapse for quite some time. And the issue here is that there's one ingredient you absolutely, absolutely need in order to heal. That is, you've got to be alive. You can't heal if you're dead. So I spent 80% of my book trying to explain to people why being off all medications, all drugs is not a good idea. Okay, because now you have no tolerance. And this kind of actually pertains to the topic we're talking about today of coming off Suboxone. Because the first question I always have is, should you be coming off it? We have to understand, if I treat addiction as a disease, it's a disease, and you don't stop your medicines until you're free of the disease and you don't need the medicines anymore. No doubt, nobody likes to take medicine. All right? Nobody likes to go on Suboxone. Nobody likes to go to methadone clinic. But we do these things because it's going to save lives. It's kind of like if you're a diabetic, I don't doubt that you don't like to take insulin shots. But that doesn't mean you can stop it just because you don't like it. So the first question I always have with trying to stop Suboxone is, should you be trying to stop it? You know?
Yeah, why do you want to stop it at this time? Real quick, you didn't mention the name of your book, Abstinence Kills, and I want to mention that. And I'm going to have links below. I do want everyone to know about this book. I think it's a very important topic. I still actually haven't had a chance except to read minor parts of descriptions of it, and me and Nicole talked about it, and I am going to read it. But I want everyone to have access to it, and I may also at some point here get it on my own website. But the book is Abstinence Kills, and I'm going to have all of the links for Dr. Fong's social media below. And so we are moving into this topic, stopping Suboxone. And I think last time we couched it in is, why do you want to stop at this time? And you're basically saying the same thing right
Oh,
now, but
okay.
please
Thank
go
you.
ahead.
Again, thanks thank you for that introduction. Yeah, the like I said, there's like you mentioned, there's a lot of stigma around buprenorphine, around it, all of addiction, and the idea here, part of it is still relates to the fact that people continue to think about addiction as a choice, and they think it's either a choice or it's a disease. It can't be both. And so if it's a choice, then addiction is always a matter of making bad choices. And if you just learn to make good choices, you won't need it anymore. And that's not quite what the disease model says. I point out that when people are have any chronic disease, and addiction is a chronic disease, almost every chronic disease I know of comes with episodes of flare-ups or exacerbations. Okay, asthma, you may be controlled for several years and not have an episode, and boom, you have a flare-up. Your diabetes can be well controlled, and then boom, you have a flare-up. All these things can have flare-ups. One of the biggest differences is that if you're an asthmatic and you have a flare-up, you don't throw away your inhalers, right? If you're a diabetic and you have a flare-up, you don't say, "Oh my God, my insulin's not working. I'm going to throw my insulin away." But people do that all the time with addiction because it's such a stigmatized thing. When they have a relapse, which is part of the course of the disease, they kind of think, "Oh my God, I'm not deserving of sobriety. It's my fault. I'm ashamed to tell my doctors, and I'm ashamed to tell my family," and they hide, and that's what leads to the disease spiraling back down. Whereas, if you would just approach it as a disease with a flare up, let's deal with it. Let's get you a bit more medicine. Let's get you more treatment, more close follow up. And maybe that's all we need to do to kind of get the condition back under control. Just like an asthmatic, I say, imagine how difficult it would be to get an asthmatic under control if they threw away their inhalers every time that they had a flare up. And imagine how much easier it might be for us to treat addiction if people didn't throw away their treatment every time they had a flare up or a setback.
Yeah, I'll validate what you're saying more, and say this. I'll add a couple of ideas to this. Number one, as far as the disease model versus choice, moral failure, and any other fantastic delusional thought process of describing what addiction is. I tell people I don't care about the ontological status of it being a disease. What I care about is that model helps me make predictions and plan treatment. Besides that, it's inconsequential and irrelevant. It's philosophically interesting, but for my clinical work, it's a disease, and it gives me a tool to make decisions, choices, treatment planning, and so forth. That's one thing. So I don't even think about it now. I might be sitting here with you talking about it at a 30,000-foot view. That's a different story. Two, you're mentioning this chronic disease thing, and I want the viewers to know that this is not just an opinion. This is not just, we choose to look at it that way. If you took substance abuse and addiction and grafted out in individual and groups' lifetimes, it fits the graphs for any other chronic disease, including when you throw in other dynamics, age, how long, number of exacerbations. So it fits that model, so it works with that disease model, and so it helps us predict. And number three, I want to point something out. You're actually bringing it right up to the surface. The stigma with it, getting rid of your thing, relapsing. Now, whether you are on subs or you're not, when a relapse happens, I want to point something to the viewer, and I'm sure you're well aware of this. When some event happens in your life, you lose your job, your significant other leaves you, there's a tragic passing of someone near you, difficult times, and you use that evening, all is not done, lost, and gone. And in fact, the technical term for it, even though in this country we still call it relapse, it's an episode of use. And if you continue to use, that can, with all of the dressings of what it is to be using, it turns in a spectrum into relapse. So when you have an episode of use, everything is not lost. Everything you gained during that time is still there, but now you have tools, and it's important you don't have the shame or guilt, and you get right back into Dr. Fong's office and say, look, I don't have any Suboxone, or I do, it doesn't matter. What do we do now? That's important. And the quicker you do it, the better. And the last thing I want to add, traditionally in this country, when someone uses, they're like relapse, and they put them back into detox. Quit your job, leave your apartment, leave your kids, wife, girlfriend, whatever obligations you are. You got to start from the beginning.
Absolutely.
That's insanity. You had an episode of use. Stop what you're doing. Call Dr. Fong or whoever your doctor is, or immediately, and address that issue so you can get back on your feet and move forward. You are not the same person today because you had use last night or the last 3 days or the last 4 days. You're not the same person as originally had this disease. If I had God forbid, if there's a breast cancer and the initial heavy work was done, let's say you even had a double mastectomy. Now at your 5-year surveillance, at the end of it, some lymph node pops up positive. You don't go back and do a double mastectomy, right? You address that in a surgical, precise way. Hopefully it's not spread. And this is the same thing. You had an episode of use. You don't leave your life that is so productive and valuable at this time and run back into detox from the beginning so you can be charged $1,000 a day for your insurances. you take care of that thing in a surgical, different way in discussion with someone like Dr. Fong.
Sure,
Is that
absolutely,
about
absolutely.
right, Dr.
The
Fong?
one other thing I would add to it, when you talk about how it maps on top of the same as any other disease, other really, really important thing that's I think pertinent to what we're talking about today is the evidence for the efficacy. What we know is when people get on Suboxone or methadone, we cut mortality by 50%. Okay, that alone is worth the price of anything because when it cuts mortality that much, I don't care if you call it a disease or a choice. If you don't believe it's a disease, if it responds that well,
Yeah,
we need to be using this medication because it's going to save lives. On top of that, it does things like stops you from coming down with hepatitis and HIV and blood clots and heart valve infections
hepatitis.
and
Yeah.
things like that. It reduces your risk of running into problems with the law and restores you to function. And so these are the evidence is, even if you don't think it's a disease, it responds so well to medications, you ought to be on these medications. But the idea here is the most important thing about these medications and why we're talking about stopping it or not stopping it is because if you stay on your Suboxone or methadone, you don't lose your tolerance. As I said, the one ingredient, absolute necessity to healing is you have to be alive. And what Suboxone and methadone does is it buys you time to heal after you get off your medicines, after you get off your drugs. After you get off your drugs, you still need time to heal. If you don't give yourself that time to heal and you get off the drugs, it just takes one mistake, and everything's undone. You know, you can win 100 battles, you just have to lose one. Okay, and that's why like I said, I call the book Abstinence Kills, because people think that abstinence is such a wonderful thing, but it takes away your tolerance and it exposes you to a lot of danger. And sometimes, when have conversations with my patients about, maybe they should stay on the medications, they say, well, doc, if I ever feel like I might relapse again, I'll come right back. I promise I'll come right back. I said, well, that's a little bit like saying, if I see that my car is going to crash into the car in front of me, I'll put on my seatbelt then. Yeah,
Oh,
you don't have
stop.
time, and
Yeah.
relapses just happen. You don't plan for them, and they just happen. And I tell people that medicines like Suboxone and methadone are not just medicines to help you find your sobriety. Very importantly, they're also like your bulletproof Kevlar vest that keeps you alive if you get shot by accident. So, it's like a seatbelt. It keeps you alive in case of an accident you didn't see coming. And it may not be an accident that, you caused. It doesn't matter. Somebody, hits you. Somebody cuts in front of you. It still can happen.
Absolutely. And, we've set up, we've sort of established how important it is to stay on this medication. There's so many nuances we could discuss here, dosing and all that stuff. That being said, okay, a lot of people want to know, hey, when can I get off of this stuff? And then how to get off of this stuff. And, I
Hmm.
think we share the same
Yes.
answer for the most part with our patients. Why don't we just dig into that? Don't we know it's important to be on this stuff? And now the question becomes,
Hmm.
a little bit how long, but that's very intimately related is how do I get off Suboxone, which is actually very related to
Yeah.
each individual person, how long they need to stay on. So
Sure.
please, you
Well,
start this
the first thing
response.
I tell people is that this is something we touched upon last time we talked about as well. The idea of agency. Okay, the four principles of bioethics. The first one is agency. I can never force a patient to take any treatment. It always has to be voluntary. So whether I think you should come off your drug or not, whether I think you should come off your medication or not, if you tell me, Doc, I want to get off my Suboxone, I will help you. Okay, because that's part of our mission as ethical physicians to make sure that we respect the patient's agency. Okay, I do tell patients that you have to want to. I'm not interested in it if it's your mom that wants you, if it's your parole officer that wants you to get off it, if it's your best friend that wants you off it. A lot of times people also think that it's a matter of swapping one addiction for another. And they call Suboxone, they call methadone legal heroin. Okay, and of course that is so far from the truth. Like I said, okay, with medicines like Suboxone and methadone, we cut mortality rate. We stop them from coming down with hepatitis C and HIV and blood clots and heart valve infections. We decrease the run-ins with the law. None of these can be done with heroin or fentanyl. Fentanyl does not do any of these things. This is not legal heroin. This is medicine. Used properly, this is medicine. Now, some people say, well, that doesn't make any sense. How can you treat an opioid addiction with another opioid? You know what? I say, nobody seems to have a problem when I prescribe nicotine gum to help people off nicotine. Okay, and this idea of fighting like with like, where you are, Dr. B, in California, there's fires, wildfires, and a lot of times, how do you fight fires? You fight fires with fires. You know, sometimes the idea here that we can't use an opioid to treat an opioid is just it's not true, and the results, like I said, they speak for themselves. Okay, so the first thing I say to people: make sure you're quitting for the right reason. I don't want you to get off Suboxone because you don't like it. There's no requirement for a diabetic to like his insulin. Okay. The second thing that you need to understand is that you should be ready. By ready, I mean you have to be mentally healthy. You have to have a stable life. You have to be you have to get out of all that entanglement. For example, if you're still fighting depression, I wouldn't suggest it. If you are still living in a drug house, definitely not. If once you establish, I tell people that when they come in to see me, I says, as a new patient, says, so what brings you here? They say, I'm here to get off drugs. That's not the reason. Okay, there's only one reason ever to come for treatment, and actually nobody's ever told me I'm wrong. The only reason coming for treatment is because you want a better life. If your life was good when you were using drugs, you wouldn't have shown up. That simple, right? So, and that's why, by the way, I tell people I never doubt their sincerity, because who doesn't want a better life? But in order to get that better life, you have to say goodbye to your old life. And that's actually the hard part of addiction, is getting rid of the old life. And I tell people it's a concept I've called out with the old, in with the new. If your pair of shoes has a big hole and your foot gets wet every time you step in a puddle, you need a new pair of shoes. If I give you a new pair of shoes, you have to take off your old pair to put on your new pair. And that's the difficult part, because stopping your old life is so difficult when you have entanglements and relationships, and it's what you know. And so you have to be out of that old life before I really think that you're ready to come off Suboxone. If you're still living the same life, hanging around the same people, thinking the same way, doing the same things, just because you stopped using does not mean that you're ready to stop your treatment.
Yeah. If I may, I'm going to go back and
Yes.
add a little something from my end on some of the great points you made. So you made the point about agency, and it's absolutely true. So one of the things I really try to, and in fact, I think we discussed this before, the foundation of harm reduction is autonomous, free-willed individual, and I try to practice that every day. Where uh, it's what you do. I'm gonna and I'll qualify this in a second, support you to the extent that I'm not hurting you, you're not hurting me, but it's not going to be any judgments, even if I don't agree with it. The one thing that I always make sure they understand is I'm not a prescription or a procedure monkey. When you come in here, uh, I have one right, and my one right is this: you come in here, I educate you in formal thinking about the choices or considerations you are having. Like I might say, okay, so you want to get off Suboxone? Here's my thought. And I might get to a point where this is not the time. Then you are allowed to make a choice, as long as I'm not facilitating where I cross that line where you're hurting yourself or hurting me or my practice. Then I'm going to show you and work with you. And the minute or if ever you change your mind, same
Absolutely.
thing. There's no judgment. I couldn't care less. I do not give a crap. I will help you. That's what I'm for. But I always reserve the right to educate you, because that's what a physician is supposed to do. I'm supposed to comfort, pain, and heal and do no harm. And a lot of that includes me educating you. And before nowadays, where everyone knows everything, it used to be my expertise, insights, and then you make a decision. So I agree with you on that agency thing. Switching one addiction to another, I always point out that's an insane thought process. Number one, you have one addiction, opiates, okay? So it's not one addiction for another. You have one addiction, opiates, and because of the way you're getting your opiates, and we just touched on this, the social milieu that you exist in, it's a deadly equation. And the solution is to switch that opiate and have it controlled and have it monitored from the outside, so that one addiction that you have doesn't kill you. So you have one addiction. How can you say you're switching one addiction for another, opiate for opiate? And this concept, as you pointed out, you used the fire thing. I let them know this is a very well established theoretical, conceptual approach to pharmaceutical treatment in medicine, whether it's, again, nicotine or benzo for alcohol, right? We've been doing this for a long time. So that's that one. And now the ready thing, I agree with everything you say. And it's basically, I let them know one thing. I say, while you're on Suboxone, and there's a magical attribute to, and you can dig into the pharmacological properties of the medication, but there's a magical attribute to this, that when you are on Suboxone, uh, what can be considered pause, post-acute withdrawal syndrome, in the long run, when you're in pause, you're still in a fight or flight mode, and you don't even know it's pause. Now, you might be having insomnia, anxiety, mood issues, but it's lit up. When it's lit up, uh, you have a more difficult time healing and getting to where you need to be in terms of cognition, mood, getting a job, all those factors that you just described. Suboxone allows you to time to build new railroads. So you have the tools. And if you're ever ready to get off, and I'd never say when, you can do that. So all those things that you said, and I always tell them, when you come in here for your visits, and we're just shooting the breeze about your kids, your job, your new degree, then you'll kind of have a feeling. I'm like, I think I'm ready. You can't really describe it, but you understand those neural networks that we're feeding into substance abuse are so buried, and there's so many layers on top, and you can make good decisions. Now we can discuss, let's start a potential taper. And so I agree with everything you said. I just wanted to add a few more things to it, and come from a different angle. But being ready means your life is, if your wife just left you and you just lost your job and you're in a panic mode, it's not a good time to start thinking about rolling off of subs. And I also add, and I'm like, look, I'm not a car salesman. How long does it take? I will say I can't answer that, and there's no data that I can put my finger on, or any recommendation I can put my finger on. You are absolutely not the same if you've been using dope for a couple of years and you're 25, now depending on your developmental background and your genetic predispositions, versus a guy who's been doing this for 45 years, can you, and there are people that might need to be on this for the rest of their life. And that reality, that potential fact declares itself in time. We will know who and what you are. I can't answer it. It's an evolving thing, both for me and for you to understand and see where you're at. So I can't answer you that. But if there is a time when you're ready, I will facilitate you to do it as best as I can. Or even if I disagree and you still want to do
So
it, I'll do the best I can.
it's actually
And
amazing how
um,
we come across the same thing with the same ideas, but we describe it differently, which is it's called external validation. But so what you said about the education is absolutely true. Like say with agency, it's like if I have a patient with acute appendicitis and I know dang well you should stay in here and let us take out your appendix. If you want to leave, I will open the door and let you leave, but not before I tell you you're going to die if you don't get this taken up. Okay, so that's an education piece, because it all has to be based on informed consent. And withdrawal of therapy is also has to be based on informed consent, which is why we're going through all this thing here today. So that is, I see it that way. I think we practice the same way. We use different terminology and different words of saying things.
I noticed that. Yeah, I did. So I thought it's a wonderful opportunity to give it to people in two
Mhm.
different vernacular, if you will, and we can reach more people that way. But I don't disagree. I think we do the exact same thing. We use different terminology, approach, use different
Yeah.
whatever, but it's
The
exactly the
the
same
one
thing.
one thing I was going to add,
Absolutely.
one thing I was going to add is that people think that Suboxone, when you're on treatment, because you will go into withdrawal if you don't have it, they think that's a sign of addiction. Withdrawal is not a sign of addiction. Withdrawal is a sign of dependency. Dependency means your body needs it. Addiction means your mind wants it. It's a different thing. So, for example, just in my case, for example, I'm dependent on my eyeglasses. If you throw away my eyeglasses, I can't function without them, but I'm not addicted to them. Okay. And there's sometimes you can have addictions with very mild withdrawal symptoms or milder withdrawal symptoms. For example, a lot of stimulants, you have withdrawal, but you're not puking your guts out. You don't have diarrhea, and most of it is fatigue and dysphoria and not feeling right. But you don't actually have diarrhea. You're not likely to die from withdrawing off stimulants. And if you look at other addictions like gambling, there is no physical withdrawal because it's not a physical addiction, but it still meets all the criteria for an addiction. So you can be dependent on something without being addicted. Like all my patients on oxygen, they're dependent on oxygen. They can't function without oxygen. Okay, but they're not addicted to oxygen. It's not that they want to do it; it's that they have to do it. Diabetics are, we call it insulin dependent diabetics. So you're dependent on treatment. As a physician, I have to say I'm perfectly fine with people being dependent on the treatments I use. If you're dependent on the oxygen I prescribe, I'm good with it. If you're dependent on the insulin you need, I'm good with it. If you're dependent on eyeglasses, I'm good with it. So being dependent on Suboxone is not the same thing as being addicted. If you stop the thing that you're dependent on, you will go into withdrawal. If you throw away my eyeglasses, I will go into withdrawal blindness. I can't see, but it's not an addiction.
I really like what you just said. Now, this one I'm going to steal from you. Uh, I'm okay with your, and I
Mhm.
call it physiological dependence. So they really understand this is a pharmacological thing. I like that. I'm going to steal that from you, those examples, because uh, dependence is sort of, and I didn't, sometimes we create the dependence. Well, no, it's always a disease process that we're trying to mitigate by utilizing the dependence part. But I
Mhm.
like that part. I'm going to steal that from you at some point here in my own stuff. But you're absolutely right. And addiction is a very different animal. The only thing I need to know when it comes time to taper, which I find out real quick through sort of a little bit of testing close. where is your physiological dependence as we do the taper or however we go about it. So let's say it is. Uh, I want to say one thing. One of the things, and then I'd like you to tell me when that decision is made. And again, it would be different for someone who you think is ready, someone who's not. Talk about some of the way. I never want to do this any cookie cutter way, but some of the ways you approach tapering off Suboxone and considerations you take. But one thing I do want to say, oftentimes I talk about coming off of Suboxone online and past videos, and I often get people saying, I'm an idiot, or I'm a quack, or have you ever been on Suboxone? It's harder than heroin, fentanyl, blah blah. Now, studies in the '70s show that that's not the case, but I don't even care about that. And I always respond to people by pointing it out. When did you come off of it? How fast did you come off of it? Were you ready to come off of it? Sure, you got a severe dependence, physiological dependence. Just because you came off of it and were in severe withdrawals, it doesn't mean that it's necessarily the Suboxone, although it's long acting and so forth, that contributes a little bit to it. But your timing was off. And so I just wanted to throw that in there for all the pundits out there. Other than that,
Sure.
if we could move into your thoughts on the various ways you approach tapering
Sure.
some of those
It's very simple.
limitations.
But the way I think you come off it is slow enough, and not if you come off it
Enough.
gradually, you won't have too much problem. It's like this with any addiction. And by the way, like withdrawal is not even something specific to addiction. Like I said, if you stop your antidepressants quickly, you can go into withdrawal. You stop you stop steroids quickly, you're going to go into an Addisonian crisis. Okay, but the idea here is with all these things, you come down gradually. How fast, how long of an off ramp you need, I can't always say. This is where the genetic thing is, and what other things you need and whatnot. But the way I do it usually is I say, you're the one that wants off it, so I'm going to put you in the driver's seat. I'm going to give you the medicines that I normally give you, and it's up to you to to cut down the use. Don't do it too quickly, because if you do it too quickly, you will fail. Okay? So, for example, if they're taking 2 strips, you can try strip and a half. If that's too much, I tell them to alternate. You take 2 strips one day, 1.5 the next day, 2 strips one day, 1.5 the next day. So it averages out 1 3/4. And after that's ready, then you go 1.5 every day. Then you go 1.5, 1.5, 1, and then you go down to 1. If you gradually come, I don't. I said there's 2 ways we can take it down. I give you less, and you have to take less, or you start taking less, and I can give you a little bit less. I prefer that way because you're in control. I don't want you to be out of your Suboxone and then go into a terrible withdrawal, and then next thing you know, you run into your next door neighbor who has a different solution for you. You come down as gradually as you need to, and I will meet you. I can either I drop it and you follow me, or you drop it and I follow you. It's a lot more comfortable if you drop it and I follow you.
I'm too much even of a coward to give him the option of them dropping it. I do make him be comfortable with the fact that I'm going to give you the same amount, and if at any time you change your mind after we drop it, you tell me. This is not me demanding you to get to a certain place. Two, I like the way you said it. As long as it takes. Now, I do pretty much the same thing as you, and I make sure they understand that. Except I do a test run the first couple of weeks to see where that physiological dependence is, and I structure it for them. I say, you know what? Let's meet up in 2 weeks. Whatever you're taking, 3 a day or something like that. And I do different things with different people, whether it's take that dose you need least, start taking days off from that dose at the end of the 2 weeks. Tell me how many days you did it, how you felt. I guide them a little more in that detail, and I'm too much of a coward to take it away from them because I'm like, dude, what if this guy, goes home, can't get a hold of me? It's too much for him. He's worried about his next appointment. So I'm too afraid because I'm not on my office practice is not that on top of that minute to minute thing. So I do the same thing, and and I let it declare itself where they're at. You know what I do find oftentimes is, especially when I advise, I don't think it's the right time, but I see that their emotional, affective disposition is I got to get this off. I let them find out for themselves because they'll be like, no way. And I'm like, this is not the time for this guy. So I let them take control, give them the same amount. What I find is as they hit barriers, whether it's for a variety of reasons that it's not time, they just kind of stop themselves right there. And, when we meet every month or whatever it is, they're like, okay, I want to hold off this month too. I'm like, that's fine, no problem. So I almost let them discover themselves that this is not time. Again, it's that agency and autonomy
That
thing that
actually,
I'm really big
I
on.
really like what you say. That's one of the reasons why I don't usually advocate another method that people hear about, which is get the sublocade shot. If you get the sublocade shot, it weans off gradually, and then you can stop it, because that way you don't have the time to discover that, wait a minute, I still need it. Okay, and so then by the time you stop it because you've had a sublocade shot, and now you start having problems again, and cravings start coming back in, you don't have another appointment to go back. Okay, so,
Oh, that's a great point. Go ahead. I'm going to give you my thought on that. That's
yeah, so
a very
for
important
that
point you
reason,
make.
I mean, people can, what I'm trying to say is this: stopping Suboxone is not just about stopping Suboxone; it's about stopping treatment. And sometimes people aren't clear to them. It's not clear to themselves that it's not time to stop treatment, and they need time to discover that, I want to get off it, but maybe it's not the best thing. Okay, and buying time for that, the self discovery is important. Can people do it with a supplicate? Yeah, I've known people to do that. Okay, I've also known people to self-medicate with things uh, like herbal stuff. Okay, like what is it? Kratom. Yeah. Okay,
Kratom?
people use kratom. Okay, these things can be used. They're not my favorite way of doing things. Kratom is a medication, and you can tell me what you think because this is also something that's regional. But kratom, it's of course not regulated, and you never know what's in the kratom supply. And I just don't trust the people who are bringing in kratom to not try to juice it up with something, and you don't know what you're getting, and there's a certain level of risk with kratom. Um, but people use it, and I think in this conversation we're having, we got to at least recognize that people do that. People do that. People try to do Sublocade or Brixadi, and they're not my preferred methods. But again, that's part of agency.
So that's interesting you brought that up. If someone's using the supplicate kind of product for that issue, and I go along with it and we move forward, I do a few things. Number one, I give them some extra subs, and the other thing I do is you know uh, I don't discharge at all, and usually some of mine are on a few other medications. There's a couple guys kind of in this space right now where we start playing with this. All right, you come in every whatever his is, 28 days or 30 days. Here's 10 extra subs. Tell you what, Let's make our appointments instead of 4 weeks where you come get your shots. I'll see you in 6 weeks. Let's see how it's all going. So that's
Mhm.
one of the things I do with the supplicate game of getting off. And then the other thing I do is I really, and my patients that have been established as my patients know this, that it's an open door policy in the sense that if you are successful, if you run into trouble into 2 to 3 to 4 months, in this office, you can come back and get on the medication because life got too stressful. You're going to relapse, and it's absolutely okay and indicated to get you back on the medication. And we start wherever and we just get to where we need to. But look, you had an 8 week run. That tells us a lot. So I approach that part that way. As far as the kratom goes, uh, um, I'm a strong critic of kratom because uh, uh, um, uh, all the things you said. And look, the issue here is this. It's not regulated, and it's not because I'm a big fan of the FDA or I'm in the pockets of the pharmaceutical companies. I couldn't care less about the pharmaceutical companies, and they probably don't like me because, but uh, and I also always add the alkaloids in kratom do have more than likely potential therapeutic benefits, but I don't think it's for you or the guy at the smoke shop to decide what that is. And just, I don't know if you have them. I'm starting to have a growing, I mean, years before anyone even knew what kratom was, I was treating kratom patients. And I have a couple on subs right now, and some I tapered, and some just couldn't tolerate it. And now I have people coming in regularly for frightening kratom withdrawals, and so I manage that. So if you told me that you were going to go do kratom to get off of Suboxone, I would say that's really no different than doing heroin, except worse because I literally don't. It might be successful. That's not the point. You have to understand. I tell them you got to understand. In medicine, I'm looking for meta outcomes so I can make individual predictions. None of that exists out there for kratom, and there are people that run into major trouble. And the dilutants of it. It's a weird situation, and I feel sometimes threatened by the kratom advocates because they're very cultish and nonsensical in their criticisms of me. I don't even know what to say. So yeah, I always make sure we do it with pharmaceutical medication. And again, uh, uh, I think I might have said this to you last time. I just got a couple of emails. I got a call from Nicole, kratom companies reaching out for me to sell kratom, and she's emailing him back. Have you seen his videos on kratom? He's the wrong guy, right? But ironically, I get comments about what a moron I am, and I'm a slave of the pharmaceutical industry, and I wish I was, but all I get out of them is a lunch or two every couple of months, and I have to do 6 signatures for that. So I'm not a slave, but that was my feedback to that. We're a little bit running out of time. I want to recap some of the things we covered, and I think that we are in agreement on a lot of things. Number one, we really, in terms of this, we discuss the importance of agency, the patient's autonomy as a human being, their free will, and how important it is. And we both agreed that it's important to respect that, but we do have the right to educate you. Then it's both in ethics of medicine, but I would say general ethical approaches to medical care. We certainly established that. Then we established some thoughts about why people should be on Suboxone long term. Switching to Suboxone, treating opiates with opiates, and when it's time to quit, are you ready and what that means? And I think we're both in agreement is that your holistic social milieu has to be in place. And that shows that it is a possibility to quit. And we both have agreed that you never know who needs to be on it for how long. I
Hmm.
think we're both in agreement there. And finally, we talked about okay, if we are going to taper, how long does it take and how do you do it? And I think we both approach it the same ways. It takes as long as it takes for that individual patient, and you try to open up opportunities for that to be sort of dialed in, less, more, you prescribe less, or they choose on their own. And I think we're in agreement on all
Nope,
of
I
those
think
things. Did I miss
that's a
anything,
good
Dr. Fong?
summary. We can always go into more detail and more granular detail, but yeah, you're right. We're probably running out of time. But yeah, these are important conversations for people to have, and the most important thing to understand that we're dealing with addiction, which is a life-threatening disease. A life-threatening disease sometimes requires medications that aren't exactly pleasant. If you have cancer and you were going to have to give you chemotherapy that's going to make you lose all your hair, I am really, really sorry. But you know what? Sometimes don't forget. And like I say, a lot of times the people who rail against Suboxone the hardest are people whose lives were probably saved by Suboxone. Hmm.
It's interesting, isn't it? Yeah, absolutely. Okay. Dr. Fong, we're going to hopefully do more of these and on other topics. As far as the viewers go today, a few things. Don't forget, Dr. Fong is in Indianapolis. I'm going to put in the links below. He has a TikTok. I know that. I'm not sure if he has a YouTube
I
or
do.
Facebook
I
yet. Do
would
you, Dr.
say
Fong?
I'm never on social networks to try to get patients. I've got really, I've got,
Yeah, I don't do
and
that either.
the idea
But
is not
but
like I'm trying to recruit new patients, and that's not it.
I'm
So
fully aware of that, but I
I
get
appreciate
to
it.
tell them about you. You're not telling them, so I get that. I've never. I don't think people even know the name of my medical practice online. Maybe there might be a link. So yeah, but he's got great information on his social media. It's pretty cool. It's like I was like, wow, it's a lot of the same stuff I do, and I actually didn't watch a lot of it on purpose so I could finish off this conversation, but I did see enough. He has a book out, Abstinence Kills. I'm going to put some links below for that. And I'm hoping actually, guys, that I we do more of these collabs with him in the future. Bring him on to the show some more, discuss other topics, potentially have some live stuff. I'm rebuilding everything on my channel, which has been rebranded to Dr. B 360. As many of you know, it should be Dr. B Addiction Recovery. But I'll keep you updated on those things. But for Dr. Fong will put all of his links below. Check out that book. Just the title itself is phenomenal, and it makes a powerful statement about the state of things, about a reality, but even worse, years into this quote unquote epidemic. I don't think we've made much headway to fight the stigma and a conceptual framework where most of this society looks at substance abuse, which makes this book even more important.
Thank you.
Other than that, Dr. Fong, thank you so much for coming on.
Thank you.
We're
Absolutely.
hopefully we'll do this again, and we'll get this up shortly. Do you
No, I
have
really
anything last
appreciate
comments?
you bringing me on and giving me a chance to kind of come up with my thoughts because at the end of the day, like I said, I'm not trying to uh, recruit new patients. I'm trying to spread information because like you, I think education is our biggest thing, and the reason I wrote this book is try to educate people to save lives, and at the end of the day. That's what I gotta maybe if I leave in parting, I say remember that addiction is a bad disease you have to heal from, but you can't heal if you're dead.
Absolutely, and so true. Everybody remember that. Again, thank you, Dr. Fang. Guys, don't forget to like and subscribe and leave your comments and questions below. We'll both check it out and give you some responses. See you guys
Thank you.
soon. Thanks, guys. Bye.